So I'd like to start my presentation. Sorry. The case is an 81 years old female, chief compliant dyspnea of effort, and past history is angina pectoris of effort, post-implantation of the ceruleum serrating stent for LAD. And hypertension, peripheral disease, and chronic kidney disease, stage 4. Estimated granular filtration rate is 21. And her chief main point problem is a liver transplant and immunosuppressive therapy, and calculated the STS score is 9.06. And she was admitted to our hospital because of heart failure with severe AES, and our heart team considered her as a good candidate for TAVR. Chest X-ray showed a little bit cardiomegaly, and EKG showed the sinus limb with bundle branch broke, and the ankle brachial index decreased because of the peripheral artery disease, and pulmonary function is normal. Coronary angiogram showed relatively diffuse stenosis in RCA, but the LCA is intact. Echocardiography shows the obvious aortic stenosis, and with mean pressure gradient of 75 and maximum peak pressure gradient is 118. And as you show, relatively a bulky calcification on the aortic root, and calcium continued to the left ventricular outflow tract. And it's normal in Japanese cohort. The small annulus is 300 and perimeter is 65. But she's not it's not a bicuspid case. So we choose evolutor because we want to avoid the annulus rupture, and shows diameter is 17. So we choose a 60 millimeter balloon predilatation, and evolutor 26 because the perimeter is 65. And this is a conventional evolutor practice. And I think you agree, the fully valve expanded, and position is not excellent, but it's a good position. And I thought the residual AR is acceptable. We can see only a mild aortic regurgitation on angiogram. And hemodynamics also identifies a good decreasement of the peak-to-peak gradient, and finally the peak-to-peak gradient is 7. So I finished the procedure without post-dilatation in this case. However, she was readmitted to our hospital because of heart failure. Why? And the echocardiogram showed a recurrence of aortic stenosis within 1 month. And short accessibility of the echo is relatively under expansion of the bioprosthesis, and with mean pressure gradient 48. Yeah, and the MDCT showed it's a very strange figure. It's crushed, or we are not sure. But enhanced CT identified no existence of the valve thrombosis, and the position is excellent, and no delayed migration. So I checked the angiogram, and the LAO showed the fully expanded bioprosthesis, but I checked the RAO view. The valve is completely compressed, and the pressure gradient is decreased again. Immediate after the procedure 7, and at 1 month is 41. So I have a mistake. I did not check the RAO view immediate after the TAVR, but because of the good hemodynamics and acceptable AR after the procedure, so I didn't check it. So question in this case, first one, is evolutor was not expanded immediate after the procedure. I think the good hemodynamics can be obtained after the procedure, but I should check the diastolic pressure is relatively decreased. So it echo showed a mild to moderate AR, but I think more aortic regurgitation can be found if we check the other position. But I expected the self-expandable valve is gradually expanded, and AR often decreases as follow-up period. And the main problem, I choose the evolutor. I want to avoid the annulus rupture. But such kind of huge calcification. But RAO view showed probably incomplete dilatation if I checked the after. This is not a case. This is a bicuspid case of mine. It's not this case. And question 2 is evolute is truly recoiled after the TAVR. So and diastolic pressure is decreased and peak to peak gradient, but 7, and within 1 month, the peak pressure gradient is re-increased. So I think not only the valve under expansion, but also the recoil, like this, gradually recoiled, I believe. And further treatment, I recommended for this patient VAV for previous evolutor, it means a post-dilatation, or sapien 3 implantation in evolutor. However, she did not want to receive any additional invasive treatment and chose the optimal medical therapy with tolvaptan and additional diuretics. So, in conclusion, ladies and gentlemen, even in the current era of refined TAVR procedure, treating patients with heavy calcification on the aortic root is still a challenge. And thank you for your kind attention.
It's a great case. Question, how many times did you recapture that valve?
No, only one.
Only one?
Yeah.
Because I mean, sometimes what you see is a fold of the valve, and the valve just doesn't open completely. And you're right, you see it in the LAO view, it looks like a beautiful valve. And you look at it in the RAO view, it looks like it is a funnel. And do you have intraprocedural echo?
Yes, I did.
And the valve appeared to be okay on echo?
Yeah, relatively okay, but a little bit under-expanded. But in our experience, we frequently see such kind of similar situation. And valve, if we incompletely valve dilated, but the pressure gradient is excellent and acceptable AR, so that is the reason why I did not check the RAO view, fluoroscopy, on fluoroscopy. Yeah.
Congratulations. I mean, it clearly was a challenging case, and the last thing we want is to have an annular disruption or an aortic rupture. And I think using a self-expanding valve in this case was definitely very well thought of. Would you consider in patients who have this amount of calcification of the aortic valve to maybe predilate, particularly because those gradients are so high and your leaflets are very bulky, knowing that something like this happened to you?
I did the predilatation using a 60 millimeter valve size, because the short diameter is 17. And please imagine we Japanese are very small annulus, so we want to do much bigger balloon dilatation, but short diameter is 17. So that is why I choose a 60 millimeter BAV. After then, I finished the procedure. But if I did, for example, the 20 or 20 millimeter predilatation, it creates some more, gets a small, large valve. Yeah.
Great case, and I want to ask you, how would you do it differently the next time? So perhaps, for cases where you're planning not to do post-dilatation, would you now routinely do an additional angle of fluoroscopy, or do you think it's an issue with the echo that you didn't get a really good image to visualize it very well?
Yeah. First of all, I should check the RAO view after the post-dilatation, and also to confirm the echo. Of course, the previous echo showed the incomplete dilation like that. So if we see some little bit open, it's acceptable. And we should check the pressure gradient.
What is the reason you think the patient refused to come back for a second procedure? Was there any complications post the first one? Was it a femoral issue or something that deterred her from coming back?
Based on the CT findings, the relatively huge calcification on the RCC and LCC, and it's a little bit trapped to the bioprosthesis the CT showed like this. So that is the reason why it's gradually compressed within 1 month.
Right. I'm just wondering why the patient did not want to come back.
Sorry, it means why she refused. Yes. And she, to tell the truth, she was transferred to our hospital, the TAVR center, other TAVR center, and she explained the informed consent is a balloon valvoplasty or balloon expandable bioprosthesis is too dangerous for her. So that is the reason why she never want to balloon dilatation. So that is the reason why she refused the additional procedure. I always checking her condition on outpatient.
I would also challenge you because I think the fact that you had AI and the fact that it collapsed means that you probably implanted too low. That's what I mean. I would assume it was too low. It seemed okay, but the radius strength at around 4 millimeters should be strong enough. Yeah. So it's really interesting how I've never seen something like this. Actually.
have we made?
Yeah.
Perfect timing here. We were wondering if Dr. Saw is here because there is no uploaded. Oh, Jacqueline.
It's not, it's I believe a wrong session.
I think the next one is
It's
Zaher
Fanari.
Fanari.
Yeah.
This one here?
Yeah.
All right. Sorry, I didn't know that you were the one I
So
thought
that's
was
the next session.
next session.
Supposed
All
to
right.
be,
Good. All right.
Thank you very much for having me here today. My case is not as interesting as the last case, but the only interesting part is the anatomy here. I thought like it would be interesting to show it as it's not reported before, so I have nothing to disclose. So we're going to talk about basically TAVR, transcaval TAVR. The only thing unique about this case is that this patient had duplicated the IVC. So she is very present lady who is actually 4'2", and who's like 356 pounds. And that's important because it's limited some of other options. And she had BMI of 45, who had she's known actually to have severe peripheral vascular disease, and we intervened on her in the past for peripheral vascular disease. She had diabetes, hypertension, hyperlipidemia, and as well as diabetic ulcer. She was known to have aortic stenosis for many years, but it became very symptomatic even at rest. She was not even able to go to the bathroom, so that's why she decided finally to let us do something for her. So that's her risk profile. As you can see, actually, her STS is not that high. She actually like probably in the lower intermediate risk there. However, as I said, frailty, she was 404, and she had very elevated BMI. I think I'm going up here. EKG is generally okay. As you can see here, her mean gradient was elevated. She had velocity of 4.7 and mean gradient of 50. So she could have gone either 23 S3 or 26 evolute. Secondary to her peripheral, which I will show you, we decided to do transcaval, and we ended up choosing to do S3. Coronary evaluation, the only thing actually was significant was one smaller diagonal branch, which have 95%, but the vessel was like 1.5, so we left it alone. So the CT, she had actually heavy calcification in the ascending aorta. That limited, and she also has severe peripheral vascular disease in her on both sides. So you can see here that she had diameter on the left common iliac artery. She had diameters of 4.4, and she had the right common femoral artery was actually occluded. So both sides were not an option. Subclavian was probably an option. However, secondary to her short status and obesity, it was really very, very, very far from the service. So the surgeons did not feel comfortable actually doing it. So when we did the workup here, you can appreciate the double IVC here. And you can see here the renal arteries. And I'll show you another picture with angio and another picture with CT in a little bit. So as you can see here, there's two IVCs, and this is the aorta. So if we get closer here, you'll see that the area here is very close to the renal arteries. And you see all this calcification. You see this branch here. So we have like very short target there to do our transcaval, but we felt this is really the only option we had. So we already planned for closure and bailout strategy. We already have a plan for Goessl self-expanding because it will go through 8 to 9 French sheet, which will go through that 4.4 millimeter iliac. So here you can see the angio again. And what you see basically here, this is vein number 1, vein number 2, And this is the artery. If you remember, the artery was completely calcified on this side. So the only area was this area here, which correlated with CT. So we were able actually to get transcaval access easily, and we'll see the closure at the end of the case. After that, basically, actually, it went very smooth. So we were able to deploy the valve. We did not have any AI. And she's very, as I say, like she's short and she's very obese, so it's very hard to see some of the images. But when we do angio, you'll appreciate more. So basically, here, if we go back here, you see the angio here. We used a GLS sheet and deployed this disc here. And you can see some flow, not much there, but no extravasation of the artery. So giving all the calcium around this, we decided to balloon this and crush the disc on the arterial side, because we wanted that disc to be really very well opposed to the arterial side. We waited 10 minutes after that. We got very good results on closure, as you can see, and there was no residual flow. So we used figure of 8 suture on the venous side. And to be honest, actually, I think like we wanted to use bare close at the beginning of the case, but her brain was very deep. We could not even get any flow. So anyway, we were able to achieve hemostasis using figure of 8 suture. So take home message basically that you can do transcaval even if you have duplicated IVC. Thank you very much.
I just learned transcaval cases because Dr. Greenbaum was at our institution and taught us. So one thing he said is, number one, is that 30–40% of people will have that flow, which
Yes.
is intentional, right? So
Yes.
the first question would be, why did you think you needed to post that? Number two, your strategy of going relatively low in the aorta, he told us that you basically don't really have a bailout because there's no stent that really fits. How would you have saved that situation?
I'm sorry, the second question, I didn't get the second question.
So he said that if you don't have enough landing zone in the aorta above the bifurcation for a couple
Yes.
percent, you might get into trouble. So he doesn't like the lower sticks that you chose there. So how?
Yes, we actually reviewed this case with him, and this is the only case. So we reviewed this case with him. We did have a little, kind of a little bit layoff there to place the graft, but we had to be very, very precise.
Okay.
So that's one of the things. You're completely right. The only issue I think we have is we were worried that with the flow, we wanted to minimize the flow. We were worried here that figure of 8 may not hold. We have some patients who had some oozing before. If she was not obese, we would be okay because holding pressure and things like this will work. Here we were really worried because we have another patient who had lost, the patient did fine finally, but they lost like 3–4 grams because they were so obese, and that figure of 8 was not completely fine. So we actually started doing this balloon there, and you're right, and if you look at the registry, even like I think the original first 100 cases, they have like I think 60% flow. But many centers are doing this now. Like our actually rate, we did like I think 20 transcavals so far, and our rate is only 5% because of this. Whether this helped or not, I don't know, but it's just, in this case, she's so obese, we were worried about bleeding, and we were worried about the figure of 8 not being enough.
So, in obviously challenging femoral access in morbidly obese patients is extremely prone to complication. And, congratulations, great work. The question that we have defaulted for those patients to, even if the iliac vessels are borderline, usually visualization is hard, trying to be precise is hard. We do them either subclavian, and if that is too deep, carotid.
Right.
Why not carotid in this case?
We, as a center, never did carotid, so we just did not feel this case. She had very short neck also, and lower bifurcation, and we did not feel like this should be our first carotid case also. Yeah.
No, that's a very difficult case that you guys tackled. It becomes more and more apparent that the more patients we treat, the more patients come or discover that have so many other comorbidities that you obviously try to do your best to make sure you treat the one thing that you can. We've also tried to avoid the inguinal area for patients who are morbidly obese, just because they're prone to, the patient can be more prone to infections or things of that nature. But I think this was a very good case. Congratulations.
Thank you very much.
I'm curious, just one last question. So
Yeah.
I'm curious about your closure device. You use a VSD occluder. I think classically they use PA occluder, am I wrong?
Yes, we usually do. They were on back order, so also. Yeah, we actually, all our other cases, we use BDA occluder, you're right. Here we were on back order. I think another reason actually why we also did this, because we did not use the BDA occluder. I think that's true. Yes. Yes. Thank you very much.
All right, Dr. Narayanan. Thank you.
Just hit start.
Oh, Stefan, sorry, I've been double-clicking this. All right, good afternoon. I'm Mahesh. I'm one of the general cardiology fellows at the University of Minnesota. First of all, thank you for giving this opportunity to present this case in front of educated people here. This is a case that was done at the VA Minneapolis Medical Center. Dr. Santiago Garcia was the one who did this, and this is our team. Rosemary Kelly is the surgeon, and other interventionists there. So this is a patient who is a 77-year-old with a NOH class 3, and I'm just giving all the frailty score and MOCA scores here for you. She had normal creatinine. Her clinical history is significant for her. The ones that I put down here are more relevant than cataracts, I feel. So CKD, diabetes, AF on anticoagulation, PAD, and coronary disease, EF of 35-40%. And she was deemed to be an intermediate surgical risk from the STS score calculation. These are echo findings. Her valve area was 0.8, peak gradient almost 69 with a mean gradient of 42. She did have mild AI. It appears a little more when you look at the images. And this is the short axis view, and then the 3-chamber view. Seems a little bit more of a AI right there. EKG just AFib. So there's no pacemaker, no AVC, not on immunosuppression. Otherwise, just concomitant for the AFib we talked about. She does have known coronary disease and never had a prior revascularization. And just a coronary angiogram before the procedure. Her LAD appeared to have some narrowing right there, but the RCA is CTO. And the FFR of LAD was 0.84. And then we bit closure. So you can see you already start noticing, and she has no history of peripheral arterial disease, but all her vessel anatomy looking not very favorable for getting a transfemoral TAVR. So TAVR measurements, area of 590 with a perimeter of 89. And she had a good coronary height greater than 10 millimeters on the two views that I'm showing. And short axis view, her dimensions here. So you can see the right iliofemoral system. This is the common that I'm showing. You see a lot of calcification. The narrow diameter is 3.6 cross 7. The left side is 3.3 cross 6. And we evaluated the left subclavian artery for access because of the bad peripheral vascular disease. I was found to have greater than 6 millimeters on the left side. That's her axillary dimensions, 9 cross 10 with no calcium. There's an angle from approaching from the subclavian artery. There's the overall diameters here, annular size 590, coronary heights are okay, and the dimensions of external iliac on the right and left both are not favorable. So this is just a slide on using alternate axis. I know we've been used to the femoral axis, but other axis really, from 2012 to 2014, you can see less than 10%. Transapical definitely went up after we started planning transapical TAVRs from the third quartile of 2012. So we chose percutaneous left axillary approach, and we chose the 29 millimeter Edward sapien valve for this. Just the anatomy, so we all know this is a teres minor muscle, so the brachial artery becomes your axillary artery, and this complete part, it's going to be your axillary, and then becomes first strip, it becomes subclavian artery, and usually the preferred access site is going to be right there, and you measure dimensions, and we got all these dimensions greater than 6 millimeter on. So this is our 4 French from the groin shooting your subclavian artery, and we're measuring. There's a micropuncture wire for the safety wire trying to access at the site where we saw. And just the sheath advancement. So this is the team of the surgeons and interventionists doing it. So first we deployed 2 perclose devices and exchanged with the Safari wire, a standard procedure like everyday procedure. And that's our implant angle here. I deployed the valve. I was 80-20, almost 90-10 or 80-20, I would say. Good implant under rapid pacing. No AI was noted on TE as well as the angiographic pictures that we got. I just wanted to open this and see what do you think of what we're dealing with here. Is it considered perforation? Could be an aneurysm. Sure. Contained perf. Yeah, I thought contained perf too. And so initially what we did was we had to go with the balloon from below and used a 9 atmosphere balloon. So it was trying to hold pressure for some time, but still there was bleeding. So at this point we decided to use an endovascular approach to use an atrial stent. So it was almost close to 38 millimeter stent. So 9 cross 38 stent was used. It's an atrial stent that we're trying to deploy here. And we positioned it, confirmed with angiogram, and post-deployment, this is our angiographic picture. So you can see this margin, the vessels intercostal are probably not compromised, and this vessel is also looking okay. So overall, we felt happy with the result that we got after we deployed the endovascular stent. So post-procedure, we got this image, showed a pseudoaneurysm with a narrow neck right there. Sorry, I should have entered the image. And then this is a 1-month follow-up for pseudoaneurysm. We felt comfortable with the conservative approach because of the narrow neck, and discussed with vascular surgery, and they all agreed with the follow-up. And you can see subclavian artery and vein, and it's a contained thing. There's no further flow after a month. So endovascular approach is being more commonly used, and you can see in some studies showing a vascular closure device are usually successful, but if they fail, treating with endovascular graft implant has been shown to be successful. The rates of almost 80 to 100% here in a few studies. And the long-term patent rate has been above 70 to 90%. There's a little difference in anatomy between a subclavian and femoral artery. Subclavian has a lot of fibroelastic medial tissue compared to a femoral artery with a lot of smooth muscle and media. Just something to keep in mind when we use these arteries for access. Well, with that, I'll stop and I'll be open for questions. Thank you.
So are you implying that with the axillary approach, incidence of pseudoaneurysm is higher than femoral approach then typically?
Yes, that's what I was reading about a few studies, and it says because you don't have a lot of smooth muscles to build resistance to avoid complications and perforation, and the vessel wall anatomy is different, so it is a little more riskier to do it at subclavian than your femoral vessels.
Would there be an advantage to give protamine for the axillary cases then to help in terms of sealing up and avoiding the pseudoaneurysm?
I think not a bad idea, but I'm not an expert definitely for commenting on. I'm sorry.
And part of the challenge in those cases is that the data is lacking about the outcome of covered stents and subclavians.
Sure.
I mean, for the reason that you mentioned, it's a very fragile artery. We've all adventured there and regretted it. What is the data? What is the data of the long-term data about a subclavian stent is covered subclavian stent is lacking, and it seems that the location is a little bit distal, but as you go in the chest cage a little bit more proximal, then the risk of thrombosis will become significantly higher.
Okay, this is late. Yeah, I mean, here it was an easy thing for us after deployment. The angle was right, and
I may have missed it in your presentation, but why did you guys choose axillary access versus a true subclavian access? What was the issue? Was there stenosis somewhere, or why did you go in that very dangerous area on purpose?
mean the
Why did you choose axillary and instead of really subclavian axis, the traditional one closer to there?
This allows
It was more
for this
distal, I
percutaneous
thought.
approach without a cut down.
so we're just doing percutaneous approach. So just this is more favorable from what I was reading. For a perc approach, that's more favorable than going
I thought
cut
just
down
from
axillary.
your pictures, you were a little more distal in the subclavian area, and you call it an axillary axis. So I was just wondering, were there no options closer, or does anybody, am I just wrong? It just looked a little more distal in the distal part of the artery, proximal. I guess proximal would be the better word.
So it appeared that you punctured close to where your A marker is, correct? Or
Right there.
Looks a little, not even more. Maybe I'm wrong.
A little closer actually, here somewhere. Between the two segments is the 1 and
Is that
2.
where you were?
Yeah. It seems a little different in this view, just a little rotated I feel,
Quite different.
because the clavicle angle is also different. Yeah.
you know, you prevented obviously you solved a very complicated vascular complication, and hopefully over the long run should do relatively well. Obviously, we don't know what the utilization of those
Right.
centers was recently mentioned. But
Right. We had a follow-up for this patient, actually came back after a year for another follow-up, but there's no further complications, no signs of any ischemia going on, so hopefully it's patent. And
what do you think the advantage of doing it over percutaneous as opposed to having a small cut down is?
it was a surgical team decision, and they combinedly wanted to try the approach, so it's combined with surgeons.
Advantage or disadvantage?
I don't know, just I can think of the healing part, maybe just getting it more percutaneous will help the patient recover early. So just wanted to try the new approach and be with the surgeons and the backup.
I don't know, you probably remember those days, but back in the old days when we started doing the interventional core valve with the risk of pacemaker, the idea is just you do a cut down, you get the TAVR, on the way out you put the pacemaker and you close the pocket. I mean, definitely
Much better now.
much better outcome right now. But we as a center were a little nervous about trying subclavian and percutaneous approach. It's a very fragile artery.
Sure, yeah, definitely.
And even with cut downs, we had
Because we saw like there was no calcium, everything was clean, and still had this complication from unexpected one. So it's not like expect.
So we just saw another one, so.
Oh, we did.
the light piece.
Okay.
Yeah.
Yep.
I'm sorry, I think I saw in your article that maybe I misread this, 8.3%. Oh, I'm sorry, I did misread it.
Oh, okay.
Overall mortality, I'm sorry.
Oh, it's
I
okay.
want
No,
to ask that.
sure. No problem. All right. Thanks a lot. Thank you.
Great.
Dr. Sato is the next presenter. Just hit the start.
Thank you, Chairman. It's my great honor to present my case here. It's my disclosure. Case was a 92-year-old female. Her chief complaint was dyspnea and peripheral edema. She was referred to our hospital because of worsening dyspnea. Her condition could be classified as the New York Heart Association Functional Classification 4. She had a medical history of hypertension and diabetes. Although she was diagnosed with symptomatic severe aortic valve stenosis 2 years ago, she did not want to undergo surgical AVR nor TAVI. This slide shows her physical examination, very small old lady, and I heard ejection murmur and nail and peripheral edema. This slide shows chest X-ray and ECG. Chest X-ray shows pulmonary edema, and ECG shows CRBBB and sinus rhythm. Laboratory data shows very, very increased BNP level. TT shows decreased EF. Her EF was 40%, but 2 years ago admission, her LVEF was 60%. And CVI's aortic valve area was 0.4, and peak velocity was 5.4, and mean pressure gradient was 77 CVIS. And this slide shows a clinical frailty scale. Her clinical frailty scale was 5, but due to heart failure, it was to 6. After admission, she was resistant to conventional medical therapy with NPPV, furosemide, tolvaptan. Tolvaptan is anti-vasopressin receptor. It's commercially available in Japan for heart failure. And dobutamine. So heart failure getting better, but easily worsening without any exertion. So we consider TAVI or surgical AVR for her, but her STS score was 25. Our heart team considered that she was candidate for TAVI. Unfortunately, we could not perform TAVI in our hospital at that time. So I talked to Dr. Yamamoto, first presenter. I used to work with him. His hospital is TAVI center, so he told me to take her to his hospital. So I decided to transfer her by myself. Yeah, it's, but Japan is a small country. It is smaller than California state, but there is many mountains and the road is very small. So if I transfer her by car, ambulance, it takes 8 hours. But using helicopter, it is only 90 minutes. Yeah. Just after arrival, the same day, we performed the 3D CT to evaluate aortic valve complex, coronary artery, aorta, and the iliofemoral arteries. So after that, we do TAVI, TF approach. Light CIA was 5.5 by 5.5, but there is heavy calcium, so it is difficult to pass the CIA, but we could make it. And after pre-dilatation, we implant the 23 millimeter Sapien 3 valve. After that, there is trivial perivalvular leakage, no transvalvular leakage. So we finished procedure. Hemodynamics changed, getting fine. After that, after TAVI, she was discharged at 7 POD without any complications. She felt so happy because she could be free from dyspnea. 2 weeks after discharge, I saw her in my outpatient department. She has no symptom, and chest X-ray is normal. After TAVI, the LVEF increased to 60%, and serum BNP level decreased to 220. I saw her in my outpatient department once every 3 months. So now she's 94 years old. She's getting fine. The last month I saw her, and she forgot her walker in my room, and she walks by her own foot. So it's very good. Transcatheter aortic valve implantation becomes a popular treatment for patients with severe aortic valve stenosis deemed high or prohibitive risk for surgical aortic valve replacement. Although previous researches reported the effectiveness and safety of elective TAVI in septuagenarians and octogenarians, it seems to be still controversial in nonagenarians especially emerging case. We had a case of successful emergency transcatheter aortic valve implantation for a 92-year-old female with severe heart failure. Thank you for your attention.
Maybe it's a totally stupid question, but I saw many cases now from Japan during this meeting, and it seems like you guys have a lot of heavy calcification throughout the vascular tree, coronaries, aorta, valve, I mean, all the endothelial sides. I mean, maybe I just don't know, but why is that? Or is it just coincidence of these cases that you
why they have heavy calcification?
Yeah.
I think one point is they are very high age, and they have hypertension and or diabetes. So, and they live longer because they have maybe they have few incidents of coronary artery death, so they can live a long term. And after that, the aortic valve stenosis getting worse. So maybe they have severe calcification.
Great job on that case. Do you think there's a role of maybe doing a valvuloplasty to help patients get a little better and maybe have a safer transfer, or do you guys practice valvuloplasty there?
Yes. Thank you for the question. We discussed same things, but this patient has no AR before TAVI. So if AR getting worse, she failed to crash, and hemodynamics getting worse. So we might lose her. So fortunately, using dobutamine, her heart failure is we can control her heart failure. And after using dobutamine, her LVEF getting better. So TAVI is best therapy for her, we think. Thank you.
How many patients have you flown?
Yeah.
Do you fly a lot?
Yeah, well, no, I fried.
Did you transport her? Were you the one that transported her to the facility? You flew her yourself?
No. I'm not pilot. Thank you.
Dr. Rassa or Rassa?
Hi, thank you. I'm Alan Rassa. I'm an interventional cardiology fellow at Oregon Health and Science University in Portland, Oregon. So thank you for the opportunity to present. I'll be talking to you about a challenging case of bicuspid aortic stenosis TAVR. And these are the other members of our valve team who are pivotal in this case. So this is a 65-year-old man with a history of known bicuspid aortic valve disease who also had hypertension and atrial fibrillation. So he'd had mild to moderate aortic stenosis, had been watched clinically for many years, no symptoms. But in the last several months, he slowly developed heart failure symptoms, some dyspnea on exertion, and he had a repeat echocardiogram that demonstrated a new decline in his LV systolic function. So you can see on this parasternal long axis view, depressed ejection fraction, apical 5-chamber view shows a heavily calcified aortic valve that's stenotic, and the continuous wave Doppler through the valve demonstrates gradients that are in the severe range. So he underwent a perioperative coronary angiography, which demonstrated a 50% stenosis in the mid-right coronary large dominant vessel, and then the left coronary system has some LAD disease there, noted the bifurcation with that diagonal. So overall, the patient had a low STS score, not a lot of comorbidities. So after discussion at our multidisciplinary valve conference, we thought the best course of treatment for him would be surgical AVR, given the bicuspid disease with possible bypass. So while he was an outpatient awaiting the planned elective AVR. He presented to the emergency department with worsening heart failure symptoms and was admitted for treatment. And after several days of diuresis, he was feeling better, and the plan was to just do the AVR during that admission. But then there was a turn of events. So the night before his surgery, he developed sudden onset chest pain just after dinner and has this EKG. So the cath lab was activated emergently, and he went there, had an acute thrombotic occlusion of the right coronary artery with a, you can appreciate, a very high thrombus burden throughout this vessel. So we wired this, and there was so much thrombus, we actually performed aspiration thrombectomy in addition to ballooning and stent placement. So at this point, with that turn of events, let me advance this. So he had a peak troponin of over 200, and at this point we paused to reassess the plan for treating his aortic stenosis. So given his worsening LV function, as demonstrated here on this echo, in addition to RV dysfunction now, we felt that TAVR might be a better approach for treating his aortic stenosis, except for a new LV thrombus that was noted. Another turn of events here. So we went ahead and performed a TAVR CTA, and this demonstrated a Sievers type 0 conformation bicuspid aortic valve and a pretty large valve area. You can see an area on the valve of 932 square millimeters and a perimeter of 108. And so we continued him on triple therapy with anticoagulation in addition to dual antiplatelet therapy, repeated imaging, but the thrombus was still there. The patient was not doing very well clinically, so we decided to just move forward with the TAVR. So we chose the core valve 34 Evolute and proceeded with the TAVR. So you'll note the there was a 4 week.
4 weeks.
Yeah, and then we repeated the echo. And
How much oversized, like out of curiosity, because this 108 feels like 4 or 5% oversized only for surgical.
It is oversized, but I don't know exactly by how much.
It's like
Yeah. So you'll note so we performed valvuloplasty with a balloon, and you'll note the wire position. We intentionally avoided putting it in the apex to avoid disrupting that thrombus.
I didn't see a sentinel device.
So we actually didn't have sentinel at that time. Yeah. Good question, though. So here we are deploying the valve. We did this very slowly, very carefully, without pacing, because we're just doing it very carefully here. You can see the first injection. We're deploying the valve. And we're happy with the position here. We unsheathed the valve a little bit more. Another angiogram, aortogram, and no leak there. And then there's another turn of events because the valve embolized into the aorta. Yeah.
I'm sure you know. So sometimes the measurements or the official land, the place where you land the valve with the bicuspid is a little different than when you land with a tightly fit valve. So that may be one of the reasons why it's a little distinct.
Yeah. So we learned from our mistakes and implanted a second valve a little bit deeper, and this time with rapid pacing too. And we used a snare, which you can see in the next shot, not on this one, to anchor the first valve in place. And here's the snare there. And then this is the unsheathed second evolute valve in position now in the aortogram showing mild paravalvular leak there. So the patient did well. There was no evidence of stroke. We did this under conscious sedation too. He was discharged on post-op day 2, did well. And you can see on this echo, you can see the two valves. It doesn't really show them in series on here, but this is the higher valve, and it had no obstruction of the arch vessels, and they're both functioning well. And then he was actually just seen in follow-up doing well with minimal symptoms. So just some conclusions. So as you brought up, TAVR valve sizing could be challenging in the case of the bicuspid aortic valves because of the morphology and the presence of an LV thrombus is not necessarily a contraindication to TAVR, especially if there's no other options, but it requires careful guide wire positioning. And third thing is that a snare can be used to anchor an embolized valve in place so it won't move when you're putting in the second valve. And that's it.
I don't know what's your experience with that Sentinel device. I mean, I'm trying to get it for a long time, and obviously everyone knows that Boston Scientific had bought the company right now. I don't know if things can change, but it's been extremely difficult with no CMS guidance, and it's still a small-sized company. I mean, I'm not sure how active they are in opening sites. So, but
they're definitely expanding, but they do have a limited workforce. And so far there's no coverage, so as long as, there will be definitely financial impact on the procedure.
I mean, these are really challenging cases. I mean, if I wrote this down correctly, you had an area of 930, I think, and your perimeter of 109, right?
Yeah.
So your 34 is actually not oversized at all.
It's 0%.
It's undersized, right? So it's really challenging because you have no valve. I mean, you can do 10 cc's extra on your 29. The engineers say it should work because of the calcification of that. I mean, it's really challenging. So, I mean, we have to congratulate it works, but you embolize, because.
And the high implant.
So in retrospect, would you? I know that the Medtronic is going to do a bicuspid trial, but in retrospect, now that you go into practice at some point, would you say, hey, surgeon, you gotta have to take this patient on, or would you try this again?
I think knowing what we learned from this one, I think we could avoid some of those missteps, and I think it can be done safely.
see, the other problem is not all bicuspid are created equal. I mean, this is clearly a Sievert 0 bicuspid, and there's absolutely no raphe. I mean, usually when you have raphe, you can count on that raphe and the calcification of the raphe, and you can have a prediction about how much this valve will open. In this case, it was a Sievert 0 valve, and I think, and you're right. I mean, the Medtronic trial is going to be extremely interesting, but how are we going to classify bicuspid because they're not created equal?
That's a great case.
Thank you.
Dr. Gedela or Gedela? How do I pronounce it correctly?
Gedela.
Gedela. All right, here you go.
Thank you.
Good afternoon, everybody. My name is Mahidar Gedela. I am a second-year general cardiology fellow at the University of South Dakota. So going into a different valve intervention. So I'm going to present a complex mitral clip intervention in a patient who had partial congenital AV canal defect repair, and then followed by ampular septal occluder repair. And she also had severe mitral regurgitation, which was operated on before and with a residual mitral valve cleft. So these are our operator interventional cardiology team. Moving forward to the case presentation, she is a 76-year-old female who presented with progressive dyspnea and exertion and fatigue of 6 months duration, NYHA class 3 symptoms. And 6 months ago, her transthoracic echocardiogram showing EF 50 to 55% and severe mitral regurgitation. Pertinent surgical history, she had mitral valve repair for congenital mitral regurgitation and an atrial septal defect closure with pericardial patch in 1994 due to partial AV canal defect, which is followed by a ampular septal occluder in 2007 due to the shunting through the pericardial patch. These were done, the 1994 intervention, I'm not sure where it was done, but in 2007 it was done in one of our hospitals in our city. Other pertinent past medical history was persistent atrial fibrillation on long-term warfarin, sick sinus syndrome, post-permanent pacemaker placement, hypertension, hyperlipidemia. She had a coronary angiogram a year ago, which showed patent coronary arteries. The initial transesophageal echocardiogram, 4-chamber view, 0 degrees, showing severe mitral regurgitation. In the right side of the corner, you may see the ampular septal occluder in the septal area. And this is the still frame showing mitral regurgitation radius of 1.4 centimeters. These are the other valve regurgitation parameters, ERO 0.47, regurgitant volume 94, consistent with the severe mitral regurgitation. And her mitral valve diastolic mean gradient was 2 millimeters Hg. These are some other views to delineate the mitral regurgitation pathology. Central jet, this is the two-chamber 60 degrees, mitral commissure 60 degrees, and then two-chamber 90 degrees, showing severe mitral regurgitation centrally directed. And mid-esophageal long axis view 140, showing severe mitral regurgitation, and AV short axis showing amplitude septal occluder device. And this is her 3D mitral valve, which is showing A2 cleft. Her valve anatomy was a little bit distorted with prior mitral regurgitation surgery. So the patient was referred for redo bypass surgery. After the heart team assessment, the patient was deemed like high risk surgical candidate with her complex anatomy. So we decided to do a mitral clip procedure after a discussion. So the anticipated challenges were we need to perform the transseptal puncture in the inferior posterior part. Usually in the regular mitral clip intervention, the transseptal puncture is superior posterior, but it may change if the valve is degenerative pathology. And because of the pericardial patch repair, so we decided to go with inferior posterior puncture. And then the mitral clip position will be challenging due to the cleft, the A2 cleft. So we thought, okay, let's go with one clip strategy first, and if she needed second clip, we will implant a second clip. The transseptal puncture measurement from the 10th area to the mitral annular area, showing 4 to 5 centimeters, which is acceptable in the 4-chamber 0 degrees view. And this is the bicaval view, showing the puncture is in the inferior. It's very fast moving. I don't have the short axis to show the posterior puncture for the septum. And this is the fluoroscopy. As you may see, the amplitude septal occluder and the mitral clip steerable guide catheter, and then the stiff amplitude septal, stiff amplitude wire is in the left upper pulmonary vein. And the first mitral clip was implanted at A1P1 scallop, and then the patient still has a pretty significant opening. Here we step back and then look into what the plan would be. So we decided that she needs to have another clip. So we checked the mitral valve mean gradient for mmHg, which is acceptable, less than 5 to 6 mmHg. So we then proceeded with the second mitral clip implantation at A3 and P2 scallop. As you may see, the mitral regurgitation severity decreased significantly, mild mitral regurgitation per the color flow imaging here. And this is the 3D imaging showing the almost equally spaced the 3 orifices and very mild mitral regurgitation. And post-procedure, her mean gradient was 5 mmHg, which is acceptable. And there was small residual left to right shunt post-procedure. We did not close this. We thought it will close eventually given the small shunt. And the clinical course, there was no pericardial effusion post-procedure and no vascular access site complications. And the patient was discharged on the next day. And the patient did well at 1 month follow-up visit with improvement of her symptoms. And we did check a transthoracic echocardiogram. At the time, her gradient across the mitral valve is still acceptable, 6 mmHg. So the discussion, the Everest 2 trial has exclusion criteria in terms of prior mitral valve surgery or valvuloplasty. and significant cleft A2 or P2, and history of atrial septal defect, whether it was repaired or not, which are the contraindications for mitral clip intervention. However, but our patient, the only option with her life-limiting symptoms were mitral clip, so the mitral clip ×2 resulted in excellent procedural success and clinical result. That's about my case. I would be happy to take any questions.
Yeah, it's a very challenging case. Did you purposely try to go to A1, B1 first, or was that just how it happened?
So it was basically how it happened. So we thought we would achieve optimal result. We can grab even the cleft area, but it did not plan as it was supposed to be. So then, given that significant opening, we decided, okay, she needs to have another clip. So we proceeded with second clip.
Normally we do use that two-clip strategy.
Mm-hmm.
We put one to bring things closer together,
Mm-hmm.
and then put a second clip to basically make the MR much better.
Sure. Yeah, thank you very much.
And then Dr. Helmy.
Hello, everyone, and thank you for organizing committee and the moderators for the opportunity to present. I'm going to use this opportunity to present to you a novel technique to prevent or minimize LVOT obstruction when doing TMVR, and I'm going to use a couple of illustrative cases. I have no financial disclosures in relation to this talk. Transcatheter mitral interventions have gained a lot of momentum. Mitral clip is now an established therapy, but sometimes patients do not fit criteria or are not a favorable candidate for mitral clip insertion. So valve in the mitral position, TMVR, has been used in valve in valve, valve in ring, and valve in MAC. The problem when you use a transcatheter valve in the mitral position, that the risk of the LVOT obstruction is reported as high to be as 30%. And the risk of development of the OT obstruction is usually related to multiple factors. Some of those are modifiable, some of those are not modifiable. The dimensions of the LVOT, you can't really change that. The angle, the aortomitral angle, you cannot really change that. Septal hypertrophy actually is one of the risk factors that some people have proposed doing a preemptive septal ablation. The length of the anteromitral leaflet and how redundant it is, especially in myxomatous valves, is a significant risk factor for developing LVOT obstruction, and the position of the valve implantation also plays a role. So pre-procedure planning, you all know about this, CT and TEE is performed. Let's talk a little bit about the aortomitral angle, and the more acute the angle is, the more risk for LVOT obstruction, because as you can see, the anteromitral leaflet will tend to prolapse and get into the LVOT. And deploying the valve, as you see in G, not only does the valve itself protrude into the LVOT, but it actually pushes the anterior mitral leaflet like a sail into the LVOT, causing significant LVOT obstruction. Keeping in mind that LVOT obstruction is more common in valve-in-native valves because the leaflets are usually more redundant. When you have a valve-in-valve, bioprosthetic valve leaflets are less likely to cause LVOT obstruction. The concept of the neo-LVOT has been described, and it can potentially predict who is at risk for LVOT obstruction. We'll skip that. So we did 3 cases using this novel approach, and this is one of the illustrative cases. All cases were deemed to be high surgical risk, not a candidate for open mitral valve replacement, and they were all deemed to be not a candidate for mitral clip because mostly of calcified restricted posterior mitral valve leaflet. This is one of the cases, and as you can see here, some septal hypertrophy, and you can see the anterior leaflet at the end of this syneron or echo run will actually oppose to that hypertrophied portion of the myocardium. So a couple of theoretical approaches have been proposed. The Lampoon procedure have been proposed by Adam Greenbaum and Bill Babliaros. It's fairly complex, where you actually go with a catheter across the aortic valve, and you bovie your way through the anterior mitral leaflet, snare that, and lacerate the anterior mitral leaflet intentionally to prevent LVOT obstruction. It's a very complex procedure. I'm sure some of the people in this room are more comfortable with it than we are, but it is definitely a complex procedure. The surgeons have adopted a different approach, and what the surgeons do most of the time is that they actually get into the anterior mitral leaflet, they create a hole in the mitral leaflet, and they position their prosthetic valve inside that defect in the anterior mitral leaflet, and they call that chordal sparing translocation of anterior mitral leaflet. So when we had these cases, we sat down as a valve team, and we thought, what is the best approach to get into this? So the proposed approach was to go through a transapical puncture and to puncture the anterior leaflet with a pericardiocentesis needle, introduce a wire across that puncture, balloon the anterior mitral leaflet, creating a defect and a hole, and deploy the valve in there. And this has been described as first in man in this publication, and I'll refer you to the rest of the team who actually participated in the publication and the procedure. So let's go through the steps, and I'll be very interested in getting input and feedback. This is the pericardiocentesis needle through the transapical approach. This is the surgeon moving the needle into the LV, and this is probably the most challenging portion of the procedure, where the surgeon has to navigate the needle to find the anterior mitral leaflet and penetrate the anterior mitral leaflet using that needle. A reasonable approach is to actually get into the apex, put a J-tip wire into the left atrium, introduce the needle over that, and then withdraw, and then you'll have a little bit more of a focused range or field rather than going blindly. This is clearly a very TEE-guided approach, and we've actually used a surface probe on the heart itself through the transapical approach. This is what it looks like on 3D. You can see the needle across the anterior mitral leaflet. This is the TEE 3D. This is a surgeon's view, and you can see that the needle actually is in the middle of the A2 position of the anterior mitral leaflet. Following that, over the wire, a transapical sheath is placed, and then a balloon valvuloplasty is performed of the anterior mitral leaflet itself. Remember, the wire is penetrating through the anterior mitral leaflet itself. You can see on the bottom here how the anterior mitral leaflet yields after the waist is, there's the waist, and pop, it yields. And that's what it looks like when the balloon is inflated through the defect in the anterior mitral leaflet. The position of the perforation is very important. If you position it too basal, close to the annulus, especially in calcified leaflets, the inflation of the balloon may actually injure the annulus. And this can potentially lead to very serious complications. If you position it too close to the tip of the leaflet, you may not get the desired result with actually minimizing LVOT obstruction. After that, over the same wire, through the same defect, the sapien valve is positioned and is deployed in the usual 70-30 approach, and then a flaring of the ventricular portion of the valve is performed. And this is a 3D TEE depiction of the valve into the anterior leaflet being deployed, and actually the sapien valve is expanding within the anterior mitral valve leaflet defect all the way, and this is the final result. There is no paravalvular leak, perfectly functioning valve, and as you can see here, the valve position is excellent without significant LVOT obstruction, and these patients did very well, 100% procedural success, and very, very good results. So in conclusions, this is a novel technique, especially in transapical, to minimize LVOT obstruction in patients who are predisposed to this potential complication. It's a fairly simple approach, although it does need a little bit of dexterity in navigation in the needle. Transapical approach at this time, we have developed another approach used for the transeptal, using the same concept of translocation of the anterior mitral valve leaflet using a balloon valvuloplasty within a defect penetration of the anterior mitral valve leaflet. Thank you very much for your attention, and if you need a reference, this would be the paper that was published. So, happy to take any questions, inputs, comments, suggestions to improve.
I mean, all these great ideas that are really, coming up now. How long do you think we're going to do these, more complicated procedures now that we have transectal mitral valves in feasibility trials? We have, how long do you think we really need this?
So, the risk of developing LVOT obstruction applies to any prosthesis developed or implanted in the mitral leaflet. So I've talked to several of the people who are involved in the trials, and Alan may actually chime in on this. A significant portion of these patients are excluded if there's a risk of LVOT obstruction. And because of the trials being feasibility and safety and efficacy, they don't want to muddy the waters with any potential complications. So if the potential is you have an anterior leaflet that is redundant and potentially would be pushed into the LVOT, using a lampoon or using the translocation technique may be of great benefit, especially the fact that if you're using a transapical approach, this is fairly easy. And as we develop the transeptal approach, this would be one extra step, is just penetrating the anterior leaflet and ballooning it. And then you deploy your valve as you usually do, and then you really don't have to worry at all about any LVOT obstruction stage.
Couple questions, great example there. So when you're ballooning, what size is the balloon?
We usually use between 18 and 20 millimeter aortic aortic valvuloplasty balloon.
So have you had issues with just torrential MR in between where you're trying to get the valve in place? I mean, that might be more of an issue with transeptal.
Correct. So what we've done actually, and we've learned from the lampoon people actually lacerate the valve and the leaflet and they get torrential MR. Because of this, our surgeons were very, very reluctant to do this without any protection. So all 3 cases that were done on cardiopulmonary bypass. And as you can see, we didn't need to pace the patients when deploying the valve in the mitral position because we had complete flow on the cardiopulmonary bypass and almost cardiac arrest or no cardiac flow.
That's a really great presentation. How do you gauge where to cross or the angle where you actually cross the mitral leaflet?
So this is, again, not easy. TEE guided, and the first case, we get through the apex, and the surgeon starts to advance the needle under fluoro, and we end up in the septum. So he pulls it back and redirects it, and he ends up in the atrium. And it takes a couple of trials until you actually get into the anterior leaflet. And then when you get in the anterior leaflet, one case we were actually too basal, too close to the annulus. So we had to withdraw and sort of move a little anteriorly and get, it's not 100%. Again, with the lampoon, you see the diagrams and the images, it's not 100%. You get close enough to where you actually have purchase on the valve, a leaflet, and then you perform your procedure. And the concept and the purpose here is to minimize LVOT obstruction. It's not plastic surgery, so you want to get a good result.
Congratulations.
Thank you. Go ahead, sir.
It's a great case, and a bunch of us under the leadership of Guerrera, we published the 1-year outcome of the valve and MAC registry. And what was interesting was that up until this point, there are more valve and commercial available valve put in mitral position than all the transcatheter, dedicated transcatheter mitral valve, all combined. And
they're still in trials though, right? The
right,
dedicated devices,
in
right?
The trial,
Right.
Implanted, there are more commercial cases done with the SAPIEN valve than all the trial valve combined.
I mean, we're interventional cardiologists, we push the envelope, right?
You give them a valve, give them a needle, they'll put it there.
I wouldn't go that far, right? You have a little bit of thought behind it too.
I mean, I actually share your concern is how long are we going to be doing this? Because obviously the challenge in valve and MAC is not just LVOT obstruction. I mean, there is the high risk of perivalvular leak, high risk of embolization. LVOT obstruction, not all LVOT obstruction are created equal.
Correct.
There are some people who do well with LVOT obstruction. Unfortunately, all complications, if you look at the 30-day data, the 1-year data, almost all complications were fatal.
Correct. So the problem is that with LVOT obstruction, as you said, not everybody has it to the same degree. But if you get somebody who gets a significant LVOT obstruction, it can be catastrophic. I mean, on the table, we've heard about cases where they had to put Impella or do ad hoc septal ablation, and it becomes a real nightmare. So the case that I showed where the anterior leaflet is extremely long and is touching on the hypertrophy septum, this was a reasonable case to be a little cautious and be preemptive about preventing this.
And I think how much perivalvular leak you're going to have because of that, and hypothetically you're slicing the leaflet in a different spot, so you're touching whatever the annulus is there with no leaflet. I mean, the idea that people have thought about when you put a valve in MAC is creating a rim of leaflets that can potentially decrease your perivalvular leak.
So I agree with you, and this is one of the points that we made is that you puncture in the middle of the A2, so you actually have a little bit of a rim, And for the perivalvular leak, you're basically deploying your valve within the anterior mitral leaflet. And as long as you size it according to the appropriate annular size, you get a nice seal rather than be in the middle of the valve with the potential for some of the leaflets to be sort of bunched outside of your TAVR or sapien and cause perivalvular leak. So we've had no perivalvular leak and very good results with this.
One more question.
Yes, ma'am.
Just think of the concept, right? So with lampoon, you're completely lacerating the leaflet.
Correct.
But in this case, you're ballooning, you're in the middle, now you're tenting it up this valve. So you might actually pull up the subvalvular apparatus, like the pep muscles. And would that change the configuration, below and?
So because we did this on cardiopulmonary bypass, we did not see any tenting of the subvalvular apparatus. We believe that if you do this under a rapid pacing, which you would usually do, you would not have a risk of significant migration atrially of the subvalvular apparatus. I think we would sort of position it right at the annulus, would anchor the sapien at the annulus without significant pull. And whether you like the laceration or you like the translocation like the surgeons do, I've talked to surgeons that say, well, this translocation, we just slice it down. And some people said, oh, you balloon it and you actually produce a laceration that is uncontrolled. Both are true. But what we've seen on the one slide that I showed you, the valve being deployed, it's actually deployed within the anterior mitral leaflet. And we see a little tiny rim out on the sort of lumen side that actually contains the valve. So I don't think the pulling of the subvalvular apparatus is going to be a major problem. We hope. We've only done 3 cases. Yeah, I mean, the concept is there, and I hope it catches a little bit of traction. Thank you very much. Thank you.
Dr. Frenchu, or how do I pronounce this correctly?
Well, that's right.
Frenchu?
French for you. No, not French. So hi everybody, I'm Kirsten. I'm a PGY2 in internal medicine over at Brown in Rhode Island. And my case is a little bit of a different flavor. We're going back to structural anatomy here. And I've entitled it Bubble Trouble. It's the first reported case of duplicate SVC with cross drainage as an etiology for paradoxical emboli. This is a brief outline, same as everybody else's, so we can skip to the introduction. So regarding duplicate SVC, even though it's very rare, it's actually the most common venous anatomy. It occurs in roughly 0.3% of the general population and an estimated 10 to 12% in patients with congenital heart disease. That's roughly every 2 to 300 patients. So I'm going to highlight some of the important considerations going forward. The case itself is that of a lovely 63-year-old female. She's got a past medical history of AFib on Coumadin. She's had prior ASD and VSD repair in her 20s. And she's presenting this time to the hospital with altered mental status, fevers, and a facial droop. And as you can see, as evidenced by the CT here, we have a right frontal brain abscess. She underwent subsequent burr aspiration. It grew mixed oral flora. And she was started on long, prolonged course of antibiotics. The etiology of her brain abscess was not clear, and given her history of congenital heart disease, she underwent transthoracic echo with bubble. So the bubble study was grossly abnormal, and upon injection of that agitated saline, you can see in the 4-chamber view here, it illuminated the left atrium and left ventricle. So that suggests a complete right to left shunt, and we should immediately stop injecting saline at that point, as those bubbles could embolize to the brain. She had this anatomy further characterized through CT and cardiac MRI with velocity mapping, which uncovered drainage of persistent left SVC into an enlarged coronary sinus, and then also identified the shunt. So a brief background on venous anatomy. So we have our normal anatomy on the left side of the screen, and then your typical duplicate SVC drainage. You will encounter patients with typical duplicate SVC. There are a few important considerations in these patients. Namely, one, as the coronary sinus sees increased venous flow, it enlarges. It's in close proximity to the SA node. So these patients are prone to arrhythmias. Furthermore, as it balloons out, you can have real thrombus formation in there. You get coronary sinus thrombosis, and then it's also important to consider any venous anomalies in the setting of procedures, particularly line insertions, namely central lines, PICC lines, also pacemakers, and everything like that. There's a lot of documentation to show a line going into the coronary sinus is associated with profound hypotension, tachyarrhythmias, cardiogenic shock, and even cardiac arrest. So to demonstrate the mechanism of cross-drainage, you can see in the schematic I drew here, we still have retained from the prior slide the left SVC draining into the coronary sinus, and now you can see the shunt itself. So right SVC into the left atrium. The role of anticoagulation in this population is highly controversial and very limited, which is obvious. The observational data we do have on right to left shunts shows there is increased morbidity related to stroke complications, TIA, and cerebral abscess. So surgery, though not typically required for usual duplicate SVC patients, was recommended in this case because of the shunt. So the last important concept here is that the bubble study did identify a pattern of flow that was dependent upon which arm was injected with agitated saline. So because she happened to have a right peripheral IV in place, when saline was injected to that arm, it showed the right to left shunt, but had it been injected into the other arm, we would not have seen the abnormality. So there may be some utility going forward in checking bilateral injections in patients with known congenital heart disease, especially in ESIS, strokes of embolic strokes of unknown source or brain abscess. So in conclusion, for your patients with brain abscess, consider paradoxical emboli, especially in the setting of congenital heart disease. Recognize that you need that TTE with bubble and that bubble studies may be limited. And be wary of your patients with duplicate SVC. Even though they're usually asymptomatic, there's potential for arrhythmia and coronary sinus thrombosis, and just be wary when you're doing those procedures on those patients. Thank you. Did you catch that? I talked really fast there.
This is a great case, and thank you for reminding us that structural heart disease is not just all about valves and holes. This is a fantastic case. What did you end up doing?
So we recommended for her for surgery, and she has declined. She's still thinking about it. She had a really prolonged recovery after the brain abscess, a lot of rehabilitation.
I plugged one, put an amplifier at the juncture of the coronary sinus, and I sent one for surgery. I mean, the challenge is, do they have collaterals to the other side? And the patient that ligated her SVC, she ended up with an extensive DVT because she didn't have robust collaterals to the other side. This is a fascinating case.
Thank you. And you?
I may have missed it, but where was the initial infection? Where did you find the source?
So we never found the source. We never found the source. We actually did the TTE in the setting of new hypoxia. She had extensive DVTs and PEs, which prompted that workup, but it wasn't initially done in the setting of her abscess.
Great.
Thank you.
And then Dr. Gerges.
Hi everyone, I'm Michael Gerges, interventional cardiologist from Aswan Heart Center, Egypt. The case is entitled NV Balloon over Veno-Arterial Rail, Overcoming Difficult Valve Crossing. I don't have anything to disclose. She was a female patient, 35 years old. She is not diabetic, not hypertensive, and she is known to have rheumatic heart disease for 15 years. She had dyspnea, NIA class 3. On examination, there was no clinical evidence of heart failure. There was a diastolic murmur of mitral stenosis, and her ECG showed paroxysmal atrial fibrillation. This is her transthoracic echo, and you can appreciate here there is a rheumatic heart disease with mitral stenosis, and the area was around 0.9 centimeter square, with a mean gradient mean of 12, peak of 22. There was a markedly dilated left atrium, her TE. There was a spontaneous echo contrast in the left atrium with no clear left atrial appendage thrombus. There was moderate tricuspid regurgitation with pulmonary artery systolic pressure estimated at 55 millimeter mercury. We planned here for balloon mitral valvoplasty. However, we had some obstacles. First, the left atrium is markedly dilated, and the left atrial volume was around 700 milliliter. So transeptal puncture here is going to be tricky and need to be not too high and not too low. And valve crossing will be challenging as well. We did a transeptal puncture in the conventional way. You can appreciate the left atrial size. It's a huge left atrium. Septal puncture was performed. Left atrium is even bigger than what appeared. 20 minutes were invested to cross the mitral valve. However, the balloon was not crossing the valve. So the plan?
You couldn't make it look towards where the mitral was?
Yeah.
Facing anywhere else within the atrium?
Yes. So we decided to rail it. So at Hiromu, long exchange wire was advanced from the balloon mitral tip. It tracked the atrial wall down to the left ventricle, crossed the mitral valve, and it was snared from arterial side and externalized, and the balloon was railed over the wire, and balloon valvoplasty was done. 3 graded inflations were performed, guided by transthoracic echo and hemodynamics data. It was a successful, with the mitral area was around 2 centimeters square. So my take-home message is that failure to cross mitral valve have been reported in around 2% of cases in some registries. Markedly dilated left atrium, thick atrial septum, septum bulge to the right side are considered predictors of failure. Vena arterial loop can also be established by using Swan-Ganz catheter or even an Achilles sheath as well. Gentle manipulation and traction are required to avoid aortic or mitral valve injury. This technique is cost-effective, safe, and it is reproducible. We did around 10 cases in our center this way, and it saved the patient from mitral valve surgery. Thank you.
That was very smart. You go back to the basics and you create a simple loop with a regular guide wire and basic procedure be 100% effective. So congratulations for thinking about that and for being able to really project that in such a
Thank you.
way.
Thank you.
We saw a case earlier today where someone didn't quite make a loop. I think it was Mark, right? So they actually captured the wire within the left ventricle and just by pushing, a catheter, like let's say, I think it was a multi-purpose or whatever the looping wire was actually into, just pushing the wire into the apex created enough strength to actually push a whole tapper system across a valve. So I wonder if you actually need the whole loop, or if you can just, snare your wire in the apex and just push down with the catheter as well. Makes it maybe even slightly easier.
Okay, what is the thing that we are usually worried about is a subvalvular apparatus.
Yeah.
We don't want to injure any cordy or something like that. I think the 2 cases were reported. They put the coiled wire that we used for the transeptal puncture. They position this wire in the left ventricle to rail the balloon over it. I think this will be more stabilizing for the balloon because this is a stiff wire. However, doing an heavy loop is, from my point of view, is much safer. Okay, thank you.